Okay, good afternoon. So today we are going to continue with the cardiovascular system. This is the third lecture on the cardiovascular system. We started with blood, and then we dealt with the heart, and today we are going to deal with the blood vessels. By definition, the blood vessels, they are a closed system of tubes that carry the blood. Either they carry the blood away from the heart, and these are the arteries which we mentioned about last time, and today we are going to deal with the types of these arteries according to the histology. So there are elastic arteries, there are muscular arteries, and there are arterioles, which, as the name indicates, they are the smallest of the arteries. And then we have the capillaries, and then the venules are going to collect this blood back to the heart, to veins, which are larger than venules, and the veins will bring the blood back to the heart. So it's not the type of blood that is carried in the vessel that decides the type of the blood vessel, but it is the direction of the blood. The arteries, actually this is not only in the arteries, but in the blood vessels in general, there is a general plan. There are three coats, we call them tunics. So we have an inner tunic, which is called the tunica intima or tunica interna, and this is lined with simple squamous epithelium, endothelium. Probably I mentioned that last time. I said that all the cardiovascular system is lined with this smooth endothelium that reduces the friction of blood and allows easy blood flow. So there is a tunica intima, which is essentially formed of simple squamous epithelium lying on connective tissue. Of course, it lies on a basement membrane like any other epithelium, and then it lies on connective tissue. And this connective tissue in the arteries has some elastic fibers which constitute what we call an internal elastic lamina. I will show you this internal elastic lamina in a moment. So we have the inner tunic, and then another coat, another tunic, which is the intermediate one, and that's why it's called the tunica media. And this one in the arteries, it is usually formed of multiple layers of circularly arranged smooth muscle fibers. These smooth muscle fibers, they control the caliber of the artery, and therefore they control the blood flow within the artery. And of course, these are the smooth muscles that are supplied by the autonomic nervous system that result in vasoconstriction, for example, when there is a sympathetic overflow. So the tunica media is essentially smooth muscle fibers. In between them, there are collagen fibers, there are elastic fibers, and the amount of elastic fibers will become much more in a certain subtype of arteries, which are called elastic arteries, or the conducting arteries, as I will show you in a moment. Then we have another lamina, which is called external elastic lamina, another lamina. I will show that the lamina, external elastic lamina, to you in a moment. So tunica interna, basically it is a simple squamous epithelium. Tunica media, which is made of smooth muscle fibers, also elastic fibers as well, depending on the type of the artery. And then the tunica externa, or adventitia, which is the outer coat, and this consists of connective tissue containing, again, collagen and elastic fibers, but more of collagen fibers, less of elastic fibers, as well as small blood vessels of the blood vessels. So they call them vasa vasorum, because here it is the same story like in the heart. The blood inside the blood vessel cannot nourish the entire thickness of the blood vessel, especially in large arteries, like, for example, the aorta and the pulmonary trunk. So the thickness of the wall is very thick and cannot depend on perfusion from the blood which is located inside the lumen of the artery. So the artery will receive blood vessels in the tunica adventitia, and these are called the vasa vasorum. The arteries, as I said, there are subtypes of arteries. There are elastic arteries, also we call them conducting arteries, and these are the largest of the arteries, including the beginning of the arteries here from the left ventricle, the ascending, the arch of the aorta, the descending aorta, even the abdominal aorta. So the aorta and its branches, its large branches, the branches of the arch of the aorta, I'm going to talk about them in a moment, as well as the pulmonary trunk, which arises from the right ventricle. All of them are elastic conducting arteries. They are so big in size. I mean, if you want to imagine them, you can see here, they are actually the size of a garden hose. So that's the size of the pulmonary trunk as it arises from the right ventricle, and the size of the aorta down to the abdominal aorta. It is so big. And these arteries, they have more elastic fibers in the tunica media. That's why they are called elastic arteries, because they have more elastic fibers. And the reason for having these elastic fibers, you can see it here in this diagram. So during ventricular contraction, let's take an example, the left ventricle. During the contraction of the left ventricle, blood will be propelled into the aorta. This results in distension of the aorta. The wall of the aorta has elastic fibers. Elastic fibers are going to stretch. Then during relaxation of the ventricle, ventricular diastole, therefore what's going to happen is that these stretched fibers are going to recoil because they are elastic fibers. So this will produce what we call a pressure reservoir. It will compress the blood again. So the blood will be compressed during ventricular systole by the cardiac muscle, and during ventricular diastole, it will be compressed by these large arteries to be distributed to the body. The blood, when it's compressed, cannot return back because there is a valve here, like the aortic valve or the pulmonary valve, these semilunar valves. So it will push them close in front of it, so it cannot return, and so it has only one way to be distributed, either into the body or to go into the lung if it was the pulmonary trunk. So these are the conducting arteries. They conduct the blood to the muscular arteries, the second category of arteries. Most of the named arteries in the body, apart from the arteries that I just mentioned, the aorta and its large 3 branches and the pulmonary trunk, most of the other arteries in the body, they are muscular arteries, like radial artery, ulnar artery, femoral artery, brachial artery. All these are called muscular arteries, and they are called muscular because you can see here there's a lot of smooth muscle fibers in the tunica media. The predominant component of the tunica media is smooth muscle fibers, while the predominant component of the tunica media in conducting arteries are the elastic fibers. You can see here the 3 tunics that I was talking about. The innermost tunic is here. It's barely seen because it's a single layer of simple squamous epithelium lying on, you can see this corrugated dark line. This is the internal elastic lamina, a lamina of elastic fibers. Then we have multiple layers of smooth muscle fibers in the tunica media, and then the tunica adventitia, which consists of collagen fibers. Between the adventitia and the media, there is another layer of what we call external elastic lamina. So here in the muscular artery, you can see internal elastic lamina and external elastic lamina. In an elastic artery, there are multiple laminae. All this thickness is full with laminae of elastic fibers. So you cannot see an external and internal elastic lamina because it is through and through. All the thickness is formed of elastic laminae. So these smooth muscle fibers in the wall, they are capable of vasoconstriction, vasodilation, and they can distribute the blood between the organs. For example, like there's, when there is a sympathetic overflow, let's say, there will be vasoconstriction of the blood vessels that supply the gut, but there will be vasodilation of the blood vessels that will supply the skeletal muscles. There will be vasodilation of the coronary circulation. So what controls this is the presence of these smooth muscle fibers in the muscular arteries. Then we have the smallest of the arteries, which are called the arterioles. They cannot be seen by the naked eye. They can only be seen under the microscope. And they are essentially formed of tunica intima, there must be a tunica intima. Whatever the vessel is, it must be a tunica intima of endothelial cells. And then overlying that, there are only few, like 2 to 5 layers of smooth muscle fibers. And these smooth muscle fibers, they are important because, again, they will help in distributing the blood, and also they will play a role in blood pressure. Their contraction plays a role in blood pressure. So how do they regulate blood flow? Here, as you can see, the arteriole leads to a capillary bed. So if these smooth muscle fibers are contracted, then their outlets to the capillary beds will be closed, and therefore the blood goes directly from an arteriole to a venule without passing into a capillary bed. And this takes place if the organ is not active, is not that much active at that time. When the organ becomes active, or a region of that organ, let's say, for example, in the brain becomes active at that moment, then these sphincters here are going to open and let the blood flush the capillary bed. The capillaries are very small, tiny. They are 5 to 10 micrometer in diameter. Remember the diameter of an RBC. It's on the average, it's like 8 micrometer. So you can see here that some of the capillaries are smaller even than the diameter of an RBC. That's why an RBC has to fold itself while navigating the capillary bed. And a capillary is only formed of endothelial cells, only tunica intima, endothelial cells lying on a basement membrane. That's all. So you can see here, for example, this is the endothelium lying on basement membrane. You can see it in actual. Look at the RBCs inside. These cells, these are simple squamous epithelial cells. They are the endothelial cells in the wall of the capillary. Look at the size of the capillary here. Probably it's maybe 7 micrometer or 8 micrometer in diameter. We have different types of capillaries depending on the function of the organ. So most of the capillaries, they are continuous capillaries, as you can see it here. This is the most common type. The plasma membrane of the endothelial cell is continuous. It doesn't have openings. It does not have windows. It does not have fenestrations, as we will talk about it in a moment. And so it is the plasma membrane of the endothelial cells. It is continuous. It is found in the lungs and connective tissue. And the ones that are present in the brain, they have a special feature. The capillaries that are present in the brain are continuous capillaries, and at the same time, they have tight junctions in between, or in the clefts between the endothelial cells. Here, the clefts between the endothelial cells, they don't have tight junctions, but especially in the brain, there are tight junctions. And this constitutes what we call the blood-brain barrier. We mentioned about that. If you go back to the brain, you will see that these tight junctions are the essential component of the blood-brain barrier, in addition to the astrocyte processes, the glial cell processes, the astrocytes. And so that any substance that is present in the blood has to be selectively chosen by the endothelial cells. It cannot just pass in between the cells, okay? So these are the continuous capillaries. The second type of capillaries are called fenestrated capillaries. Fenestra, fenetre means window. So they have multiple windows, as you can see, in their endothelial cells, which means that there is a lot of exchange can take place. This, for example, happens in the kidney, for example, in the small intestine for absorption, in the kidney for filtration of the blood into the nephron of the kidney. Endocrine glands, they need fenestrated capillaries because when they secrete their hormones, the hormones should go to the blood. So it should have an easy access to the bloodstream. So that's why the capillaries, they have multiple windows. And then the third type of capillaries are called the sinusoids. The sinusoids are large capillaries. They have large fenestra, as you can see. Compare these openings with these. And it's not only the endothelial cell that is fenestrated, but even the basement membrane. Look at the blue basement membrane. It is also incomplete. It is also fenestrated. which means that there is a lot of substances, large substances can pass. Blood cells can pass. And this happens, for example, in the bone marrow, in the liver, in the spleen, okay? So that in the bone marrow, the blood cells that are produced in the bone marrow can have easy access to the circulation. In the liver and the spleen, the worn out RBCs, for example, they will move out of the circulation and will be phagocytized by the cells of the lymphoid tissue, as we will see that in the next lecture. So essentially there are 3 types of capillaries. So here again I want to emphasize that the thin wall of the capillaries, because they are only formed of endothelial cells, a single layer of endothelial cells, allow exchange of nutrients and wastes between blood and tissue. Now the venules, they are small veins, as their name indicates, and they have again tunica intima and tunica media, which contains smooth muscle cells. Then they drain into larger veins. Here you can see this is a vein here, and you can compare between the vein and the artery. Here's an artery, here's a vein. So for a comparable size of a lumen, the vein has much thinner wall than the artery, because the blood inside the vein is under less pressure than the artery. Isn't that right? So that's why the wall of the vein is much thinner. Not only so that's why the vein is easily compressed. When you press, you can, first of all, you can compress the vein. And even when you dissect, you will find that the veins, they have very thin walls and they are usually compressed. And the wall here, it has only few layers of smooth muscle fibers in the tunica intima, in the tunica media. Again, so there's tunica intima, there's tunica media, and tunica adventitia. But the tunica intima is narrow, is thin. If you compare it with the tunica intima of an artery, there are less elastic fibers in the vein. And although it is not very clear in this vein, but actually the tunica adventitia, the outermost tunic, is the thickest of the 3 tunics in the vein. In the artery, it is the tunica media that is thickest, but in the vein, it is the tunica adventitia. And what is the component of the tunica adventitia? It's just connective tissue, no smooth muscle fibers. Now, venous return, how does the blood returns back to the heart? It's either by the pumping action of the heart, or because the main reason here, one of the main reasons actually, is the presence of valves in the wall of the vein. You can see these valves. They look like the cusps of the semilunar valves. So they are cup-shaped, and they allow unidirectional flow of blood. So the blood moves from lower part of the body to the upper part of the body, and when it wants to return back, it will close the valve in front of it. So that's why it will move, let's say, step by step, because here there are multiple valves, like these valves, throughout the length of the vein. So the blood moves step by step. What causes the blood to move step by step? It is the surrounding muscles. So the muscles, the other factor, important factor in venous return, is the skeletal muscle pump, especially the muscles of the calf, the back of the leg. Okay, that's why we need to move these muscles. If you sit for a long period of time, like for example in an airplane across Atlantic, then you need to move, or at least you need to dorsiflex and plantar flex while you are sitting in your place, so that to prevent stagnation of blood, and this might lead to thrombosis, clotting of blood. And these muscles, they act as a peripheral heart, peripheral pump. Sometimes also even when we yawn or we extend our muscles of the upper limb, all this will result in the contraction of muscles, and it will compress the veins, which already have a thin wall, and it will move the blood. The blood moves in one direction only because of the presence of the valves. And same thing here happens if you watch this movie here, this short video, if you watch this short video clip, you will find that there is a soldier in the parade who stood for a long period of time, and then suddenly he fell down because of the pooling of blood. He was not moving, and the blood pooled down, and there is less blood reaching his brain. And then there is the respiratory pump, which is made mainly by the contraction of the diaphragm. In the wall of the thorax, there are, in between the ribs, there are muscles which are called external and internal intercostal muscles. You can see them here, and we have studied them in the muscular system. See, these are the external and internal intercostal muscles. Now, when the external intercostal muscles, they contract, they will elevate the ribs. And you can see here, the anterior end of the rib is lower than the posterior end of the rib. So when it is elevated, this causes increase in the anteroposterior diameter of the thorax, like a pump handle. That's why they call it pump handle mechanism. And then also when the rib elevates, the central part of the rib will become elevated, like a bucket handle. And when you move the bucket handle away from the bucket, you can see that there is an extra space here, which means that there is an increase in the transverse diameter. And so this increases the transverse diameter of the thorax. If you want to increase the volume of any compartment, then you have three choices. You increase the anteroposterior, you increase the transverse diameter, and you increase the vertical diameter. So now we have already increased two diameters. In order to increase the vertical diameter of the thorax, then the diaphragm, which is already dome-shaped, contracts. And when it contracts, it is pulled down, becomes at the level of the dotted line here. And this will increase the vertical diameter of the thorax, causing negative pressure inside the thorax. And this will suck in the air. At the same time, as the diaphragm contracts, it is going to increase pressure where? When the diaphragm contracts, the pressure is increased in which other cavity? In the abdominal cavity. Its pressure is increased in the abdominal cavity. And this will compress on the veins that are present in the abdominal cavity. And already there is a negative pressure in the thorax, and then the venous blood will pass from the abdomen into the thorax. The blood in the veins cannot return down because of the presence of valves. So all these mechanisms, they work together. Not all the veins in the body are accompanied by arteries, and we have superficial veins. We mentioned that probably several times about them. We mentioned that in the skin. They are present in the subcutaneous tissue. They are used for phlebotomy, and they are important for the control of the temperature of the body. So there are superficial veins, and these superficial veins, they communicate with the deep veins. And there are valves in the communicating veins. If these valves become deficient, then the blood will pass from the deep veins, which are accompanied by arteries, to the superficial veins. And so the superficial veins will become dilated, tortuous. They are just under the skin, and this is what we call varicose veins. And this could be either congenital, it could be mechanical, because of venous thrombosis, or could happen during pregnancy, for example, because the pressure of the fetus on the abdominal and pelvic veins will prevent the blood coming from the lower limb. So this will result in varicose veins. So if these valves, they fail because of excessive pressure, they fail and the blood returns back, causing the veins to become dilated and tortuous. We have this definition, which we probably mentioned before, is anastomosis, is that when two or more arteries, they unite together, mouth to mouth, anastomosis, stoma, mouth, and this is important to create what we call a collateral circulation. So collateral circulation is important. If one of these arteries become narrow or fails, then the other artery can compensate. It can bring blood to that region or to that organ. An example of a collateral circulation is one that is present in the base of the brain, which is called the circle of Willis. And it is formed by the union of branches of internal carotid and vertebral arteries. This was mentioned when you studied the nervous system. And another example, which was studied last time when we studied the coronary circulation, we said that there are right and left coronary arteries. They have branches. The branches anastomose with each other. Okay, so they can provide a collateral circulation to a certain degree of narrowing. But if the vessel becomes very narrow, then the collateral circulation will not be enough, and this will result in ischemia or infarction in that organ or that tissue. Some of the organs, some of the tissues are supplied by end arteries, which means that these arteries, they do not anastomose. So once the artery is blocked, then this is very dangerous. Means that the tissue supplied by it has no other option to receive blood, and so this results in ischemia and infarction. This is the systemic circulation. We talked about it last time. We followed the route of blood from left atrium, left ventricle, then the aorta, and then to the rest of the body, and then returning by veins, either inferior vena cava or superior vena cava or the coronary sinus to the right side of the heart. So the blood leaves the ventricle into the first part of the aorta. This very short segment of the aorta is called the ascending aorta. It's a very short segment, but it supplies two very important arteries. These are the coronary arteries that supply the wall of the heart itself. And then we have the arch of the aorta. Remember the size. It's the size of the garden hose. And this is the arch of the aorta. It has three branches. You can see the branches here. You need to memorize. I mean, there is a lot of memorization here. I'll try to simplify things as much as possible. Like, for example, these supply the head and neck and the upper limb. So the first branch is called the brachiocephalic trunk. Brachio means that it's going to divide into a subclavian artery, so it supplies the upper limb. Cephalic, it supplies the head via the common carotid artery. Then we have the left common carotid and the left subclavian. So the left common carotid and left subclavian, they arise by themselves from the arch of the aorta, but the right common carotid and right subclavian, they arise from a common trunk, which is called the brachiocephalic trunk. So we have three arteries arising from the arch of the aorta. And then the descending aorta has multiple small arteries. Some of them supply the lung, bronchial arteries, because the lung cannot depend on the blood that reaches the lung via the pulmonary arteries. Pulmonary arteries, they carry deoxygenated blood to the lung. But the lung tissue itself needs oxygen, needs nutrients. So there's another set of small arteries called bronchial arteries that supply the lung tissue itself. And these are derived from the descending aorta, some branches to the esophagus, branches to the spinal cord, and to the wall of the thorax. This is the subclavian artery. If you follow the subclavian artery, it becomes the axillary artery, and then the brachial artery. And then in front of the cubital fossa, it divides into radial and ulnar arteries. The radial is on the lateral side, and the ulnar is on the medial side. Please remember the location of the bones, radius and ulna. So that's why this is where we can feel the pulsations of the radial artery. It's in front of the radius, distal end of the radius, in front of the distal end of the radius. The subclavian artery has an artery which is called a vertebral artery. Here you can see this vertebral artery that passes through foramen magnum and supplies the brain together with the internal carotid artery. Here is the brachial artery. This is the artery that we use when you measure the blood pressure. So when you measure the blood pressure, have you measured blood pressure yet? Not yet? Okay, so when you measure the blood pressure, you have this cuff, sphygmomanometer cuff. This is inflated around the middle of the arm. You inflate it above the systolic blood pressure. Usually it should be 200 millimeter of mercury or even 210. And then you start so that to make sure that the brachial artery here is compressed. No blood is going to pass through the brachial artery. And then you put a stethoscope on the cubital fossa in front of the elbow joint. This stethoscope is medial to the tendon of biceps. You can feel your tendon of biceps in front of the elbow joint. If you compress the biceps, go medial to it and feel the pulsations of the brachial artery. Tendon of biceps in the middle, go medial to it, you will feel the pulsations of the brachial. This is where you put your stethoscope. So when you deflate the sphygmomanometer cuff to the level that is below the blood, when you reach the systolic blood pressure, blood starts to pass through the artery with a sound, because the artery is still compressed. It has started opening gradually until a level is reached where the entire artery is open. This is the diastolic blood pressure. No sound is heard. It is as if that you are having the same garden hose and you compress the garden hose, then either water will not be able to pass, or when water starts to pass as you decompress, you will hear whoosh, the sound of water. And then when it is completely decompressed, no sound is heard. So you compress you inflate the sphygmomanometer in the middle of the arm, and you hear the sound of blood in the brachial artery in the cubital fossa. This is where you can feel the pulsations of the brachial artery, medial to the tendon of biceps. Common carotid is going to divide into external and internal carotid arteries. As the name indicates, external supplies everything outside the skull, and internal carotid goes to inside the skull to supply the brain after it anastomoses with the vertebral artery here at the circle of Willis. The aorta passes below the diaphragm into the abdomen, where it becomes the abdominal aorta. So in the thorax, it is the thoracic aorta, and then becomes the abdominal until the level of L4, where it divides into two terminal branches called common iliac artery. Whenever you hear the word common, it means that the vessel is going to divide, either external, internal, or superficial and deep. So it's going to divide in one way or another. So this is the common iliac artery, divides into external iliac and internal iliac artery. Internal iliac artery supplies the viscera of the pelvis, and the external iliac artery, as you can see, goes straight forward, downward into the thigh to become the femoral artery. So the abdominal aorta has multiple branches. Some of them supply the gastrointestinal tract. These are unpaired branches. We have the first one is the celiac trunk, then the superior mesenteric, and then the inferior mesenteric. You need to know which structures are supplied by which. And then there are paired branches like this one, renal arteries, two renal arteries, and then gonadal arteries. Gonadal means that they supply the gonads. So the gonadal arteries, they arise from the abdominal aorta. Although the ovary, which is supplied by the gonadal arteries, is present in the pelvis, or the testis, which is supplied by the gonadal artery, is present in the perineum. You know the reason for that? Why do we have the gonadal arteries arising high up in the abdomen, and then they supply the gonads, which are far away from the origin of the artery? Any idea? Yes, it is related to that. So actually the gonads, to start with, they develop in the abdomen, and then they descend down. So as they descend, they drag their blood supply, nerve supply, lymphatic drainage, they drag it with them. But the journey of the ovary ends in the pelvis, while the testis continues down into the scrotum. Okay? So that's why when you are hit on your scrotum, then you will feel the pain in the abdomen. Okay? Because the nerves, they come from higher up to supply the testis. Now these are again the visceral branches of the abdominal aorta. I'm showing them to you now, but we are going to also study them when we deal with the gastrointestinal tract. So we have the celiac trunk, which supplies the stomach, part of the duodenum, pancreas, spleen, and the liver. And then we have the superior mesenteric, which supplies almost all the small intestine and the proximal part of the large intestine, and then the inferior mesenteric, which supplies the distal part of the large intestine, does not supply any small intestine. These are the arteries of the lower extremity. As I said, that the external iliac artery continues into the femoral artery. It was mentioned that this femoral artery is located in the femoral triangle in the superior medial part of the thigh. It is midway between the anterior superior iliac spine and the pubic symphysis. You can feel the pulsations. It is easily accessible, and that's why a catheter can easily pass through this femoral artery. It is also a big-sized artery, so they can pass a catheter through the artery and reach up back to the heart. Okay, and then the femoral artery goes behind the knee joint into the popliteal fossa, where it is called the popliteal artery, where again you can feel the pulsations of the popliteal artery by deep palpation in the popliteal fossa. And then it divides into anterior tibial and posterior tibial arteries. The anterior tibial artery is located in the front of the leg and continues on the dorsum of the foot as the dorsalis pedis artery. As its name indicates, it is the dorsal artery of the pied, of the foot. So dorsalis pedis, where again you can feel its pulsations. Here, pulsations of these arteries, you need to know where you can feel these pulsations, and you can do that on yourself or on your partner, because especially these arteries, the distal arteries in the lower limb, you need to examine them, especially in patients with diabetes, patients with atherosclerosis. They are the first arteries that become blocked. So, and they can be easily palpable. So as I mentioned, the femoral artery is palpated in the femoral triangle. Here's where you can feel the pulsations of the popliteal artery. You need to flex the knee joint, and then by deep palpation you can feel that, but it is much easier to feel the pulsations of the dorsalis pedis artery, and probably more easier to feel the pulsations of the posterior tibial artery behind the medial malleolus. Remember the medial malleolus at the distal end of the tibia, on the side of the medial side of the ankle joint, you can feel the pulsations of the posterior tibial artery. The veins, they drain blood back to the heart, as we mentioned. I'm not going to go into these details. I probably mentioned all of them. There are superficial and deep veins. Also, the pulmonary circulation, I went through the details of the pulmonary circulation last time. And here I want to stop to mention about the portal circulation. Do you remember the portal circulation that was mentioned before? Have you heard of the portal circulation before? It was probably 2 weeks ago. Yes. Okay, so there's a portal circulation between, we mentioned about it, it's a small portal circulation between the hypothalamus and the anterior pituitary gland. What is a portal circulation? It is a vein that carries blood from one capillary network to another capillary network. There was a capillary network in the hypothalamus and another capillary network in the anterior pituitary. That's how the hypothalamus controls the anterior pituitary, through this portal circulation. Now, the biggest portal circulation is present in the liver, hepatic portal vein. And here, the hepatic portal vein, it carries the blood from the entire gastrointestinal tract. This blood is full of nutrients and carries it to the liver. So the liver receives two sources of blood supply. It receives a hepatic portal vein and a hepatic artery. The hepatic artery is even smaller than the portal vein, because the blood that is carried by the portal vein is deoxygenated blood, but it is full of nutrients for the liver to work on or to store. But the hepatic artery, it carries the oxygenated blood to the liver. So this is the meaning of a portal circulation. Then the last slide is about the fetal circulation. Probably I mentioned about the fetal circulation last time. I said that there are veins, oxygenated blood comes from the placenta, and this oxygenated blood bypasses the liver, reaches the right side of the heart, and then from the right side of the heart bypasses to the left side of the heart through foramen ovale, and so that's because there is no lung to be inflated here, and then the blood returns back to the placenta via what we call umbilical arteries. So the umbilical arteries here, they carry deoxygenated blood from the fetus to the mother, while the umbilical vein carries oxygenated blood from the umbilicus to the fetus.